And the last application I'm going to go over today is exon level array CGH. As we call it at GeneDx, it's exon array DX. And it's a new application of oligonucleotide microarrays. Exon level array CGH is intended to detect deletions or duplications within individual exons and introns of targeted genes. And our current design uses a uniform coverage of 7 probes per exon and 250 base pairs flanking the intron sequence of that gene for over 500 genes. And it allows detection of deletions, duplications as small as 150 to 250 base pairs. And all of our positive results are confirmed by another method, qPCR or MLPA. And so exon level array CGH is a very useful tool in autosomal recessive disorders when only a single mutation is identified by sequence analysis. In a case example regarding the PAH gene for PKU, we recently identified a single missense mutation, R408W, in exon 12 by routine sequence analysis in a patient that was presenting with classic symptoms of PKU. And this mutation has been reported previously in association with PKU. At this point, we were questioning, does this patient have a large deletion on the other allele? And so on exon array, we did identify a deletion from intron 4 to intron 5, to exon 5. And large genomic deletions have been previously reported in approximately 0.5% of patients with PKU. And so for this family, the presence of these 2 mutations is consistent with the diagnosis of PKU. Obviously, if they were inherited on different allele and trans, and at our lab we would follow up, but I don't think in this particular case the parents had been tested yet. Another useful application of exon array CGH is that it includes carrier detection for gene deletions in X-linked disorders. So previously, by routine PCR and sequence analysis, you can't detect deletions in females that are carriers of X-linked disorders. And here's an image of a partial FLNA gene deletion that includes exons 3 through 9 in a female with X-linked periventricular heterotopia, and showing that she's a heterozygous carrier. And heterozygous carriers for this disorder often do have symptoms including seizures and cardiovascular problems. And to just sum up that exon level array CGH, the useful application is to detect full and partial deletions or duplications, including single exon. Again, can be used to confirm array CGH results, and also to test for deletions, duplications in disorders with multiple related genes at once. Testing for, and again, to test for known familial deletions or duplications. And so exon level array CGH of these 3 gene-specific methods has the highest sensitivity. It can detect deletions and duplications as small as 250 base pairs. It's really easy to customize and modify the array design, and so if there's a gene that on the design that we currently have that to call GeneDx and investigate, and likely have we can redesign the array and come up with another version that includes that gene. The disadvantages is that sometimes it can obviously lead to reflex the whole genome array CGH, again, to determine the boundaries of the deletion duplication that you're seeing if it's a whole gene. And so to highlight some specific advantages and disadvantages of these 3 gene-specific deletion duplication techniques, I just want to discuss one last case that I touched on earlier about the FLNA gene. And the FLNA gene is located on chromosome XQ28, and it's quite a large gene. It includes 48 exons. It encodes for the filament A protein. And typically, for loss of function mutations in this gene, it results in X-linked periventricular heterotopia, which is when neurons are failing to migrate to their proper position early in the fetal brain development, and it forms clumps along the ventricles, as you can see in that scan. The white arrows are pointing to the heterotopias. And this condition is lethal in males, and females have seizures, psychiatric problems, cardiovascular abnormalities, and they also can show the periventricular heterotopia. And the case that came to us, it was a mutation confirmation case. There was an affected female in the family that was previously tested at an outside laboratory. This individual had sequence analysis and MLPA. And this outside laboratory did identify, they reported it as a possible deletion of exon 4 in the FLNA gene by MLPA. And the reason they were stating it was possible deletion is that they didn't have another methodology to confirm the result. And the mother currently was pregnant and is seeking prenatal diagnosis. And just of note, we looked up the available MLPA kits for the FLNA gene, and the outside lab likely used a kit that included probes in exons 4, 11, and 40. And so for such a large gene to only have 3 probes, you're sort of limiting your sensitivity there. And so we ran this individual, the proband, on exon level array CGH and revealed a heterozygous partial deletion of exons 3 through 9 and confirmed this result by qPCR. And large deletions of the FLNA gene have not been previously reported in association with X-linked periventricular heterotopia. However, as I mentioned before, many other loss-of-function mutations have. And so in this case, we were able to confirm the possible deletion the outside lab saw, and we also were able to further identify the extent of the deletion, as well as provide prenatal diagnosis for this family. And just to summarize, I hope this made it into your slides. It's a comparison chart of these 3 techniques. I'm not going to go over any of these, but if you have questions towards the end, or if we run out of time, you can approach me and I can address them.